Today we are going to study the respiratory portion of the respiratory system. I would like to remind you with the type of the epithelial lining different parts of the bronchial tree. We started by the trachea. Trachea is lined by the respiratory epithelium, the pseudostratified columnar ciliated with goblet cells. Extrapulmonary bronchus has the same structure as the trachea. Intrapulmonary bronchus lined by pseudostratified columnar ciliated with goblet cells. Bronchiole lined with simple columnar ciliated and partially ciliated with Pleura cells and few goblet cells. Terminal bronchiole simple cuboidal epithelium partially ciliated with Pleura cells. The respiratory portion of the respiratory system is formed mainly or started from the respiratory bronchiole. And actually the respiratory bronchiole is different from the terminal bronchiole in that we can find here some alveoli open in the respiratory bronchiole. When we go deeper in the lung, the respiratory bronchiole gives rise to alveolar duct and finally alveolar sac. So this diagram represents the respiratory portion of the respiratory system. Start from the respiratory bronchiole, alveolar duct, and the end is the alveolar sac and alveoli. Lining epithelium of the respiratory bronchiole is a simple cuboidal epithelium which is ciliated in the upper portion and it loses its cilia when we're going down in the lung. The alveolar duct is also lined with simple cuboidal epithelium. Alveolar sac is mainly formed of two or three alveoli joining each other or unite with each other, forming a large sac, and this sac and its alveoli is mainly lined with simple epithelium named pneumocyte cells or pneumocytes. And we have two different types of pneumocytes in the alveolar sac and alveoli, pneumocyte type 1 and pneumocyte type 2. Here is a slide from the lung stained with H and E, methoxylin and eosin, and we can see here the terminal bronchiole give rise to respiratory bronchiole, and from the respiratory bronchiole we can find more than alveolar duct, and finally alveolar sac and alveoli. As we mentioned, in the alveoli we have alveolar epithelium. The alveolar epithelium is of two different types, pneumocyte type 1 or type 1 pneumocyte and type 2 pneumocytes. Here is the diagrammatic illustration for the wall of the alveoli, and we can find the pneumocyte type 1 cells here. It is gray and the nucleus with the pink color, and pneumocyte type 2 green color, and we can find also the alveolar macrophage or dust cells. So the epithelial lining of the alveoli is formed of type 1 and type 2 epithelial pneumocyte. The macrophage here we can clearly notice that the macrophage is not attached to the wall of the alveoli, so it is not considered as one of the lining cells of the alveoli. It is rather free cell. Here we will mention some about the morphology of the pneumocyte type 1. Pneumocyte type 1 is typical squamous cells, so it is flattened epithelial cells. The nucleus and the organelles accumulated in the center of the cell. The remaining part of the cell represented by cytoplasmic extensions, which is actually very cytoplasmic extension, which are very thin, about 0.3 to from 0.1 to 0.3 micron in thickness. And the pneumocyte type 1 has no microvilli, so it is very delicate and very thin cell, covering about 95% from the alveolar alveolar surface, and actually this structure and this very fine and delicate structure is adapted for its function. The gas exchange occurs through between oxygen in the alveoli and the blood in the blood capillaries, pulmonary blood capillaries, through the cytoplasm and the basement membrane of the type 1 pneumocyte, as we will discuss later. Type 2 pneumocytes are large cells. So type 1 is small cells, type 2 are large cells. They cover 5% of the alveolar surface. The cell has a cuboidal shape with a central rounded nucleus. The cytoplasm has a characteristic component which is called lamellar bodies, can be seen with the electron microscope, and this lamellar bodies contains the surfactant phospholipids secreted by type 2 pneumocytes. So the function of pneumocyte type 2 to secrete pulmonary surfactant, and we will discuss and mention the function of surfactant in details in the next slide. And also pneumocyte type 2 can divide and give both 1 and 2 pneumocytes, so it can give rise to its own type, and it act as a precursor or stem cell for the type 2 pneumocyte in case of damage. Surfactant component of pneumocyte type 2, which is present in the form of lamellar body, is a very important phospholipid that can prevent collapse of the alveoli on expiration, and it allows the alveoli to retain some of air after expiration, and so it prevent its collapse, and it facilitates its distension with the next inspiration. So it is very important for the lung function. Also, some components of the surfactant other than phospholipids are of immunological function, and is a part of the immune defense mechanism of the pulmonary tract. So in this slide we will discuss insufficiency of surfactant, which is very famous in infants delivered by cesarean section, or premature infants, or infants for a diabetic mother. They are suffering from tachypnea, increase in the rate of respiration, and the difficult respiration within the first few minutes after birth. And this condition is called neonatal respiratory distress syndrome. Such neonatal respiratory distress syndrome is mainly caused by decrease or insufficient surfactant. So the lung collapsed, and it is very difficult to breathe. And in such case, the first aid or the first treatment of choice is glucocorticoids or cortisone. The cortisone increases the production of surfactant and resolve this problem. Alveolar macrophage are present freely in the alveolar wall and the interalveolar septum. They are absent at birth and appear during neonatal life. Origin, they are originate either from the circulating blood monocyte or some resident fetal monocyte in the lung. Function, phagocytosis of dust particles, so sometimes it's called dust cells, bacteria, or other foreign substance in the alveoli or interalveolar septum. Heart failure cells are actually alveolar macrophages that engulf red blood cells in case of congestive heart failure. Aging changes can affect the proliferation and function of the macrophage of the lung. Here is a diagrammatic explanation for the development of the macrophage. Here we can find during fetal life, some of fetal monocyte in blue color go to the lung and transform it into this resident macrophage. And by aging, the lung is exposed to viral infection, pollution, smoking, and such hazardous situation invite the blood monocyte to the alveoli or to the lung, and such circulating blood monocyte here in red color by different and recurrent exposure of the lung to such environmental problems or such infection increase in number within the lung and can replace completely the resident macrophage, which represent here by the blue color. So the blue color start from the first, most of the macrophage are resident and develop from the fetal monocyte, and after that the resident macrophage replaced with the monocyte derived alveolar macrophage, and it increased with age. This slide represents the interalveolar septum. The interalveolar septum is the lung parenchyma between two adjacent alveoli. The interalveolar septum is formed of two main components, the alveolar epithelium, pneumocyte type 1 and pneumocyte type 2 on both surfaces, and in between is the interstitium. The interstitium is formed of continuous blood capillaries and connective tissue cells and connective tissue fibers. Also, the alveolar macrophage can be found here in the interalveolar septum. As we can see, some of the interalveolar septum are very thin and other areas are thick. The thin area is the place where gas exchange takes place between the blood capillaries and the oxygen in the alveoli. Again, the interalveolar septum, by definition, it is the region between two adjacent alveoli. Structurally, it is formed of alveolar epithelium on both sides of the septum and the interstitial tissue. The interstitial tissue is formed of continuous blood capillaries and interstitial connective tissue. The interstitial connective tissue show interstitial connective tissue fibers, collagen type 1 elastic fibers, and reticular fibers, and the connective tissue cells, fibroblasts, smooth muscle cells, and also macrophage. The blood-air barrier it refers to the cellular structure that lies between air in the alveolar sac and the blood in the capillaries. Starting from the alveolar lumen, the barrier is formed of surfactant lining the alveoli, type 1 alveolar cells, basal lamina of both alveolar cells and the capillary endothelial cells, and the non-fenestrated or continuous endothelium of the blood capillaries. So these are the layers of the cells in between air in the alveoli and the blood in the continuous capillaries. So if oxygen will pass from the alveoli to the blood in the blood capillaries to be carried out by hemoglobin, it will pass through the following layers: surfactant from the alveoli to the blood capillaries, surfactant type 1 alveolar cells, it is type 1 pneumocyte, basal lamina of the alveolar cells and the basal lamina of the endothelial capillaries fused together, and finally the endothelium of the blood capillaries. This structure is collectively called the respiratory. This diagrammatic illustration shows the different layers and different components of the respiratory membrane or blood-air barrier. And if we will follow oxygen during its trip from the alveoli to the erythrocyte within the blood capillaries in the interstitium, in the interalveolar septum, the oxygen will pass through surfactant, cytoplasm of pneumocyte type 1, fused basal laminae between the pneumocyte type 1 and the endothelium of the capillaries, and finally the endothelial cells of the capillaries. This structure is collectively, as we mentioned, called or defined as a respiratory membrane. What is the pleura? The pleura refers to a serous membrane that line the lung and the thoracic cavity, or more correctly cover the outer surface of the lung and line the thoracic cavity. They permit efficient and effortless respiration. Types of pleura, we have two different layers of the pleura: visceral pleura, which cover the outer surface of the lung, and parietal pleura, which line the thoracic cavity. And between two layers of the pleura, there is a small amount of serous fluid. Each layer is formed of mesothelial cells, simple cuboidal epithelium resting on a connective tissue rich in collagen and elastic fibers. The connective tissue of the visceral pleura is continuous with the lung parenchyma. Here is a diagrammatic illustration for the thoracic cavity with the both lungs, and each lung is surrounded with serous membrane. The serous membrane is called the pleura, and we have two layer, double layer membrane. Inner layer is the visceral layer, which cover the outer surface of the lung except around the hilum, and also it is in green color here, and the blue color represent the parietal pleura which line the thoracic wall. And between the visceral pleura and parietal pleura there is a potential space with very minimum amount of serous fluid which allow smooth movement of the lung during inspiration and expiration without. Both slides represent the pleura, visceral layer of the pleura attached to the lung parenchyma, and here we can find the epithelium and the subepithelium or mesothelium, simple cuboidal epithelium, some mesothelia connective tissue in pink color here, and the lower one is a higher magnification of the upper one. We can see the cuboidal epithelium and the connective tissue continuous with the lung parenchyma. These two slides represent the visceral pleura attached to the lung parenchyma. The upper one we can see a thick pink colored line surrounding the alveoli. This is the visceral parenchyma attached, visceral pleura attached to the lung tissue. Lower one is a higher magnification for the upper one, and we can see here the epithelium and the subepithelial connective tissue, which is called the visceral pleura, attached directly to the lung tissue. And outside it's the pleural space between visceral and parietal pleura. The parietal pleura is not demonstrated here because it is attached to the costal wall and the inner aspect of the thoracic wall. Pleural effusion, it is a pathological condition. As we mentioned, between the two layers of the pleura, visceral and parietal layers, there is a potential space with very minimum amount of fluid, of serous. In some pathological conditions like infection, malignancy, tuberculosis, heart failure, renal failure, a large amount of fluid will be accumulated between both layers of the pleura, and in this case the respiration will be very difficult as inflation and deflation of the lung cannot occur correctly or in efficient manner. And in such a case, as we can see, there is a device which is fixed in the potential pleural space just to drain this fluid outside of the pleural cavity, and in such case the lung can move freely and it can improve the respiration until the underlying cause will be treated. Pleural biopsy for histopathological examination. Sometimes the physician need a histopathology for the pleura just to make sure of the diagnosis or to help the physician to reach a professional diagnosis for the case. So the needle will be cone-shaped, and the biopsy should include the following. Pleura, part of the visceral pleura, part of the parietal pleura, the subpleural or subepithelial connective tissue, some of the adipose connective tissue, and sometimes part of the skeletal muscle from the costal wall. The histopathological examination should be done to examine the components within the pleura and outside the pleura in the surrounding connective tissue. This helps a lot to understand the pathological conditions, especially in some chronic inflammatory disorders or in some malignant cases. The structural unit of the lung is the pulmonary lobule. The smallest structural unit of the lung is the primary pulmonary lobule, which is that part of the lung tissue supplied with one alveolar duct, formed of alveolar duct, alveolar sac, and alveoli. If 4 to 5 primary pulmonary lobule will collect together, they will form what is called pulmonary acinus. The pulmonary acinus is that part of the lung supplied with a single respiratory bronchiole. From 3 to 24 pulmonary acinus will form what is called secondary pulmonary lobule. Once more, the pulmonary acinus portion of the lung parenchyma supplied by a single respiratory bronchiole. Size of the pulmonary acinus is from 7 to 8 milli in adults, and from 3 to 24 acini will form the pulmonary lobule, secondary pulmonary lobule. Primary lobule, it is that part of the lung parenchyma associated with single alveolar duct. It is smaller than the acinus. And from 4 to 5 primary lobule will form acinus. Here is a diagrammatic illustration for the primary pulmonary lobule. Here is the alveolar duct, alveolar sac, alveoli, and we can also notice the blood supply for the primary pulmonary lobule in the form of pulmonary artery and pulmonary vein, and it is also connected with the lymphatic drainage and the lymph node of the pulmonary lobule. The alveoli contain also lymphocytes, both B and T lymphocytes, especially killer cells, and so the lymphocytes within the alveoli are considered as very important for the defense mechanism. Finally, in the bronchoalveolar lavage, we can find some substance, some chemical substance, which coat the bacteria and make it easy for the macrophage to recognize and phagocytose such bacteria. So such chemical substances act as immunoglobulins and opsonins. So what are the non-respiratory function of the lung? The main function of the lung is gas exchange, but some other functions the lung can do. First is converting an inactive chemical precursor into active precursor, like turning angiotensin 1 into angiotensin 2, which help in reducing blood pressure. Also, it is essential for degradation or inactivation for some chemical substance like bradykinin, serotonin, and norepinephrine. The bronchial mucosa can secrete some factors like polypeptide and polypeptide hormone as calcitonin, serotonin, and the gastrin releasing factor. The pulmonary epithelial cells also act as immune defense cells. So these are the non-respiratory functions of the lung. Aging process affect the lung, and we can find such histological change in the lung. Increase in the number of goblet cells, presence of chronic inflammatory cells, narrowing of air passage, dilatation of the alveoli, senile emphysema, and a decrease in the number of resident macrophages. All these things affect the respiratory function and also affect the immunity of the lung. So the senile persons suffer from difficulty in breathing, sometimes hypoxia. They also are more susceptible to infection and pneumonia. Thank you for your attention.